Now let's talk about the male urogenital triangle. So in the male urogenital triangle, we have the penis and the scrotum. Now let's talk about the penis. Penis has a fixed root and a body that hangs freely. So when we talk about the penile root or the root of the penis, we have three masses of erectile tissue. The erectile tissue, we have a bulb, which is the bulb of the penis, and then we have two crura. Okay, so we have a right crura and a left crura. So the bulb is going to be situated in the midline, and it is going to connect the inferior surface of the perineal membrane or the superficial surface of the perineal membrane. It is going to attach to the superficial surface of the perineal membrane. Urethra is going to traverse the bulb. So here we can see the urethra traversing the bulb. Okay, so BU towards the bulb. And bulbospongiosus muscle is going to cover the exterior surface of the bulb. So we have BU, bulbospongiosus muscle, the urethra, which are outside or which are covering the bulb of the penis. Now let's talk about another mnemonic, which is CPI. So here we are going to talk about the crus. Each crus is attached to the side of the pubic arch. And ischiocavernous muscle is going to cover the entire surface. And the bulb is going to continue into the body of the penis and form the corpus spongiosum. So I have another mnemonic for you here, which is CC and CS. Okay, so bulb is going to continue to the body of the penis and it is going to form the CS, which is the corpus spongiosum. And the two crura are gonna anteriorly converge and lie side by side in the dorsal part of the body of the penis, and they're gonna form the corpus cavernosa, CC. Let's talk about the body of the penis or the penile body. It has three cylinders of erectile tissue which are enclosed in a tubular sheath of deep fascia, which is also called the Buck's fascia. The tissues are two dorsally placed corpora cavernosa and one corpora spongiosum, which is ventral. The corpus spongiosum is going to expand at its distal extremity in order to form the glans penis, which covers the distal ends of the corpora cavernosa. The pronounced posterior edge of the glans is the corona. Okay, so we have a corona here as well. So we have corona, meatus, and foreskin of the penile body. So pronounced posterior edge is the corona of the glans. So these are the parts of the glans, right? And the slit-like orifice of the urethra is the external urethral meatus at the tip of the glans. At the tip of the glans we have orifice, and posterior edge of the glans is corona. And then we have a foreskin or prepuce, which you must know about. So foreskin is a hood-like fold of the skin that covers the glans. And then we have something which is called a frenulum, which is going to connect the foreskin or the prepuce with the glans. It is a tissue fold that connects foreskin to the glans, just below the urethral orifice. And we have two condensations of deep fascia, which are suspensory ligaments of the penis. They are going to extend downwards from the linea alba and the pubic symphysis, and they are going to attach to the fascia of the penis. So LP and F, linea alba, pubic symphysis, and fascia of the penis. They are basically going to support the body of the penis. They are condensations of deep fascia. Now let's talk about the blood supply of the penis. So first of all, the skin and superficial fascia of the penis is going to be supplied with what? External pudendal artery, which is a branch of femoral artery. Now let's talk about some deeper parts. So some deeper parts of the penis are supplied with the internal pudendal artery. Corpus cavernosa and crus are going to be supplied with the deep artery of the penis, which is going to give off the helicine arteries as well into the spongy erectile tissue of the corpus cavernosum. Now let's talk about the bulb of the penis. Bulb of the penis is going to be supplied by the artery to the bulb. And the artery of the bulb of the penis is also going to supply the corpus spongiosum as well as the glans penis. Please remember that deep is going to supply two muscles like corpora cavernosa, and dorsal is going to supply only one. Deep is for two and dorsal is for one. Now let's talk about the dorsal artery of the penis. Dorsal artery of the penis is going to run along the dorsal aspect of the penis, and it is going to run deep to the deep fascia, and it is going to supply the skin and fascia as well. So skin and fascia is also going to be supplied with the dorsal artery of the penis. Okay. Veins are going to correspond to the arteries. EVD, please remember EVD for that. Erectile bodies are going to drain into the venous plexuses. Erectile bodies are going to drain into venous plexuses with V, which are going to drain into the deep dorsal veins. Okay, large deep dorsal veins, EVD. And the veins are gonna run under the pubic symphysis through the genital hiatus. And then they're gonna go towards the prostatic venous plexus in the deep aspect of the pelvic cavity. Now let's talk about the lymphatics. So the skin of the penis is going to be drained through the medial group of the superficial inguinal lymph nodes. Now let's talk about the erectile body, which is going to be supplied with the internal iliac lymph nodes. Now let's talk about the nerve supply of the penis. So first of all, we are gonna have a pi for that. So remember pi for the nerve supply. We have pudendal nerves as well as the inferior hypogastric plexus, P and I, right? So pudendal nerves are gonna give somatic nerve supply to the skeletal muscles and the skin of the penis. And then we are going to talk about the autonomic nerve supply by the inferior hypogastric plexus to the smooth muscles, including the vascular smooth muscle of the helicine arteries as well. Now let's talk about the scrotum. So scrotum is an outpouching of the lower part of the anterior abdominal wall. It is going to contain testes, epididymis, and lower ends of the spermatic cords. Now let's talk about the blood supply of the scrotum. So please remember SPAV. as well. Subcutaneous plexuses and arteriovenous anastomosis are going to promote the heat loss, and so they are also involved in environmental control. We're going to talk about the blood supply, external pudendal artery from the femoral artery, and the scrotal branches of the internal pudendal arteries, and the veins are going to accompany the arteries. Let's talk about the lymphatic drainage. So wall of the scrotum is going to have lymphatic drainage from the medial group of the superficial inguinal lymph nodes, and testes and epididymis are gonna receive lymph from the lumbar or para-aortic lymph nodes at L1. Also remember that descent of testes is going to come from the post-abdominal wall and then through the internal inguinal canal towards the scrotum, and the blood supply and vasculature is also going to be changed accordingly. Now let's talk about the nerve supply of the scrotum, which is a little bit difficult. So remember IG as in Instagram first, and then I want you to remember PP. Okay, Instagram profile picture. Just remember Instagram. Okay, whatever. So the nerve supply of the anterior scrotum is going to be ilioinguinal nerve and genital branch of the genitofemoral nerve, ING. Posterior scrotum is going to be drained with PNP, which is a pudendal nerve, which is a major nerve in terms of coverage, and then also the posterior femoral cutaneous nerves, PFCN. We're going to talk about the superficial perineal pouch of the male urogenital triangle. So likewise, we are going to have a bulb and the crura, which are going to form the root of the penis, and then we are also going to have some muscles, which are going to cover the root structures. So these muscles are bulbospongiosus and ischiocavernosus. And then we are going to have STP, which is superficial transverse perineal muscles, and also branches of pudendal nerve and internal pudendal vessels. Now let's talk about the muscles in detail. So bulbospongiosus muscle is present one on each side of the midline, and it is going to cover the bulb of the penis and the posterior portion of the corpus spongiosum. They are going to compress the penile part of the urethra and empty it of semen or urine, which is residual. And the anterior fibers are also going to compress the deep dorsal veins of the penis. They are going to impede the venous drainage of the erectile tissue and assist in the erection of the penis. Let's talk about the ischiocavernosus muscle. Ischiocavernosus muscle is going to cover the crus on each side, and it is going to compress the crus penis, and it is going to assist in erection as well. Now let's talk about superficial transverse perineal muscles, which are going to lie in the posterior part of the superficial perineal pouch. Each muscle is going to rise from the ischial ramus and it inserted into the perineal body. They're going to fix the perineal body in the center of the perineum. Now let's talk about the nerves of the superficial perineal pouch. So we're going to have a perineal branch of the pudendal nerve on each side, which is going to terminate in the superficial perineal pouch and supply the muscles and the skin. Now let's talk about the perineal body. Perineal body is a small mass of fibrous tissue which is going to attach to the center of the posterior margin of the perineal membrane. It is a point of attachment of external anal sphincter, bulbospongiosus, and superficial transverse muscles. So now we're going to talk about deep perineal pouch. So the structures we can see. Deep perineal pouch is present between the perineal membrane and the inferior fascia of the pelvic diaphragm. In males, it is composed of membranous urethra or the intermediate urethra, part of the external urethral sphincter, which is sphincter urethra, and it also has bulbourethral glands, deep transverse perineal muscles, and some vessels like internal pudendal vessels and branches. And we also have the dorsal nerve of the penis. So now let's talk about the membranous part of the urethra or the intermediate urethra. It is only 0.5 inches long. It is the shortest and least dilatable part of the urethra. It lies within and is surrounded by the inferior part of the external urethral sphincter. It is going to continue above with the prostatic urethra and continue below with the penile urethra. Now let's talk about the sphincter urethrae muscles. When we talk about external urethral sphincter, it is upper, larger, and more vertically oriented part, and external urethral sphincter is going to extend up along with the prostatic urethra and then until the neck of the bladder. So EP and external urethral sphincter towards the prostatic urethra and then the neck of the bladder. Only the inferior portion of the external urethral sphincter, which is present between the perineal membrane and the prostate, has a true sphincter-like unit which is encircling the intermediate part of the urethra. This segment is the sphincter urethrae muscle, and the sphincter urethra is going to compress the membranous part of the urethra, and it is going to relax during micturition. This is a voluntary urethral sphincter. It is supplied by the perineal branch of the pudendal nerve, like in the superficial perineal pouch supply. Okay. Now let's talk about the bulbourethral glands, which are two small glands in the deep perineal space. They are embedded in the sphincter urethrae muscle. Their ducts are going to pierce the perineal membrane and enter the penile portion of the urethra. They are going to pour their secretion into the urethra when erotically stimulated. And then let's talk about the deep transverse perineal muscles. Deep transverse perineal muscles are going to form a flat sheet-like mass. They are superior to the posterior part of the perineal membrane and posterior to the sphincter urethra, so SPPS. Each muscle is going to come from the ischial ramus and pass medially to insert into the perineal body. They're going to fix the perineal body, but they're clinically not very important. Now let's talk about the internal pudendal artery, which is going to pierce the perineal membrane and then enter the deep perineal space, so IPD. And then it is going to pass forward. It is going to give rise to artery to the bulb of the penis, deep artery of the penis to the crus of the penis, and dorsal artery of the penis to the skin fascia of the penis. Okay. And now let's talk about dorsal nerve of the penis. So it is going to pass forward through the deep perineal space and supply the skin of the penis. Now let's talk about the male urethra. Male urethra is 8 inches long. It extends from the neck of the bladder to the external meatus of the glans penis. So N to M, neck of bladder to meatus on glans penis. It is divided into 3 parts. First part is the prostatic part, second part is a membranous or intermediate part, and the third part is a penile part. First of all, let's talk about the prostatic part, which is only going to be 1.25 inches long. So prostatic part is going to pass through the prostate from the base to the apex. So niche se upar. It is the most dilatable and widest part. Now let's talk about the membranous part, which is only 0.5 inches long. It is going to pass through the sphincter urethra and the perineal membrane. So it is going to pass through the S and P, PS, and it is the least dilatable portion. Now let's talk about the penile part, which is the spongy urethra. It is very long, it is 6 inches long. It is going to run through the bulb and the corpus spongiosum of the penis, and external meatus is the narrowest part of the entire urethra. The part that lies within the glans is dilated to form fossa terminalis or navicular fossa, and the bulbourethral glands are gonna open into the penile urethra below the perineal membrane. Now let's talk about erection of the penis. So erection in the male is gradually built up as a consequence of various sexual stimuli like pleasurable sight, sound, smell, and other psychic stimuli, fortified later by direct touch, sensory stimuli from the general body, skin, and the genital skin, results in a bombardment of the CNS by afferent stimuli. So for the afferents, we are gonna have sense cells, okay? And then for the efferents, we are gonna have what? For the efferents, efferent nerve impulses are going to pass down the spinal cord to the parasympathetic outflow in the pelvic splanchnic nerves S2, S3, S4 of the sacral segments. Then the parasympathetic preganglionic fibers are going to enter the inferior hypogastric plexus and synapse on the postganglionic neuronic fibers. Postganglionic fibers will run through the prostatic nerve plexus, a subdivision of inferior hypogastric plexus, and then they are going to join the cavernous sinus. Preganglionic fibers to the inferior hypogastric plexus towards the postganglionic fibers, PIP, and then we're going to get PC. So prostatic nerve as well as the joining of the cavernous sinus says, and then they're going to pierce the pelvic floor and join the IPA, which is the internal pudendal arteries, and they are going to distribute along their branches, which enter the erectile tissue at the root of the penis. Parasympathetic stimulation will cause vasodilation of the helicine arteries, causing a great increase in the blood flow through the cavernous sinuses, through the cavernous spaces of the erectile tissue. The corpora cavernosa and the corpus spongiosum will become engorged with blood and expand, compressing their draining veins and the surrounding fascia. By this means, the outflow of the blood from the erectile tissue is retarded, so that internal pressure is further accentuated and maintained. The penis will increase in length and diameter, and it will become erect. Once the climax of sexual excitement is reached and ejaculation actually takes place, or the excitement passes off or is inhibited, the helicine arteries will undergo vasoconstriction, and then penis will return to flaccid state. Now let's talk about ejaculation. With increase in the sexual excitement, the external urethral meatus of the glans penis will become moist. So meatus of the glans is going to become moist as a result of secretions of the bulbourethral glands. Frictions of the glands, reinforced by other afferent nerve impulses, will result in a discharge along the sympathetic nerve fibers to the smooth muscles of the duct of the epididymis, as well as the vas deferens on each side, and the seminal vesicles in the prostate as well, so EVSP. The smooth muscle will contract, and spermatozoa, along with the secretions of the seminal vesicle, the prostate, will discharge into the prostatic urethra. The fluid will then join the secretions of the bulbourethral glands and then the penile urethral glands, and then it is ejected from the penile urethra as a result of rhythmic contractions of the bulbospongiaceous muscle, which compress the urethra. Meanwhile, the internal urethral sphincter of the bladder will contract and the detrusor muscle will relax, preventing the reflux of spermatozoa into the bladder, which is retrograde ejaculation. The spermatozoa and the secretions of the several accessory glands will constitute the seminal fluid or the semen. At the climax of the male sexual excitement, a mass discharge of the nerves will take place in the CNS. Impulses will pass down the spinal cord to the synthetic outflow T1 to L2, and the nervous impulses will pass to the genital organs that are supposed to leave the cord at L1 and L2. In the preganglionic synthetic fibers, many of these will synapse with the postganglionic neurons in L1 and L2 as well. Other fibers may synapse in the ganglia in the lower, lumbar, or pelvic part of the synthetic trunks. Postganglionic fibers will distribute to the vas deferens, the seminal vesicle, and the prostate through the inferior hypogastric plexuses.